My name's Chris Walker. I am a senior physiotherapist at Amputee Rehab. So we work here mainly as an outpatient service, trying to rehab patients that have had amputations, mainly lower limb. There are obvious differences in terms of potentially reasoning why the person's got low back pain. And so obviously, potentially it could be that it's to do with adaptation, it's to do with malalignment, it's to do with repetition of certain movements that's kind of caused it. So that's one of the things that's maybe quite difficult in terms of thinking about treatments of that person, because you're never going to be able to fully avoid doing the activity that they're doing if they're walking around. So it's a lot of it is kind of management and trying to make sure that the patient's educated. If you know that what you want to be treating, whether it's muscular, whether it's kind of joints or anything like that, then you can do obviously some specific treatment techniques, the same as you would do other patients. A lot of the patients can still get into prone, can still get into side lying, can still get into supine. However, moving through those positions might be a little bit more difficult. Yeah. So it's very much kind of trying to target, pinpoint maybe the cause. And again, it depends on how long sometimes they've been an amputee. They may have had low back pain prior to them being an amputee. So actually it might be a chronic kind of problem that actually just exacerbated by what they're doing. In terms of generally, the patients would have their own exercise program from coming out after being an inpatient. The national guidelines for amputees give a certain amount of exercises called peer pack exercises. Okay. However, then we do generalised kind of cardio exercises, upper limb exercises, and then obviously if the patient is presenting with kind of low back pain and kind of problems that are irritating from that, we would maybe give them exercises specific to that, but we would still, I would err on the side of functional exercises rather than giving any kind of specific kind of McKenzie exercises or anything like that that's kind of specific to low back pain, because at the end of the day, whatever exercise they do needs to be functional for the patient, and if they're using a prosthetic leg, then they need to be able to adapt between their movement function with the prosthesis or without the prosthesis as well. So there's no set program that I would give them. A lot of it is very functional. It's very much trying to make sure that they're doing all the generalised stuff to get themselves in nicer condition. Postural stuff is key, especially with people in wheelchairs quite a lot. Yeah. Trying to make sure that they're aware of that. Core stability exercises, very much integrated into their early rehab, and then trying to get them to continue that throughout as well when they're up and walking. And then obviously looking at postural alignment when they're walking as well. Depending on the walking aids, that can obviously change people's position, also can have an effect on people's back pain and how far they're walking and what kind of walking aids they're using as well. So I guess we give them specific exercises to be doing at home, but then also kind of try and look at them generalised in terms of when they're up and standing in different postural sets sort of thing as well. Okay. Scoliosis and adaptation like that probably occurs after quite a long period after being an amputee, and depending on that level. Obviously the higher up you get in terms of amputation, obviously the more likely that is to occur. For our transtibial patients, I don't see that it tends to be so much of a problem. For transfemoral ones, it more so is, and for the few kind of hip dysarticulation patients that we see, it's quite evident that's going to be a big issue because of the mere fact of the muscles that you're using on your back are completely different compared to if you're trying to use a prosthesis. So we link in, we've got orthotics team here that we link in with that do braces and that help us to try and fit those braces alongside the prosthesis if needed. We'd also obviously give kind of like an exercise program as best we can, but also look at the function of the person as to what they're trying to do on a day-to-day and how they're doing it, and whether the person's trying to get from A to B or just do things because that's what they want to do, or whether they're doing it quality or quantity of the exercise and try and educate, because actually the patient's education of what they're doing, why they're doing it, and what they're causing the body to do is probably the key factor to actually whether that's the scoliosis is going to either improve or whether the muscle function is going to improve, and how they're going to be kind of continuing on, and how long they're going to be a prosthetic user for. So it's kind of like taking a bit of an MDT approach, but hopefully they don't get to that stage of where they've got that adaptation. Obviously, it depends on what's led the person to get to the surgery. There's maybe key differences between some of the traumatic patients and then some of the more vascular patients and more elderly that have had ongoing problems prior to the amputation itself. I guess key things are social factors, support and everything like that in terms of what they've got in place to help them progress, and then also in terms of their goals and commitments that they've got that want to move on to, so work commitments and family commitments, and just key things. We're always on the lookout for yellow flags, but I would say the population of patients that we have in general, the ones that kind of come through here for prosthetic training, are very keen to get up and get going and get back, and those are the sort of patients that they're not the ones that kind of rest on the laurels, that don't want to progress. It's in their benefit because of the fact that they want to be able to access their house, different areas of the house that they can't normally access because of the wheelchair, because the doors aren't wide enough to get around, so they don't want to be living in one room, they want to be walking around the house. And so I think that has actually, have that background awareness of yellow flags, but actually it's just kind of, I think a lot of the patient group actually are very proactive in terms of trying to progress on. The ones that aren't, then we would obviously try and put support structures in place in terms of linking in with either services, linking in with the occupational therapists to try and help them through the different factors for adaptations and the home environments to make things easier. And also we've got cognitive behavioural therapists here as well that we can kind of link in with as well, that if we know that people are really struggling, that can help them bring them through those situations as well.
Okay. How much do you know about CBT?
Yeah, I mean, this patient group in terms of CBT is kind of key. We have a living well with amputation course that we run here. So alongside kind of we've done 3 courses so far, about 6 weeks program that we've linked in with our psychologists that kind of who do the CBT program to help on a basic CBT approach, however, just to try and educate them a little bit more. So that goes hand in hand with what we do in terms of the primary patients to progress them through their first year. Obviously the patients that aren't progressing well, and we feel there's a lot of factors to whether it's just recognising the fact that they've had an amputation, acknowledging their stump, acknowledging what they can and can't do. CBT is it seems to quite help in terms of open up the patients to talking that little bit more, and kind of recognising that potentially some of their thoughts that they've got about what's happened or why it's happened, what's led to that point where they are, actually there are different reasons that can help them through that, and I think CBT seems to have helped quite a lot of the patients.
Do you think it directly influences back pain?
In terms of the back pain, I think it has a good effect. If the patients have got the back pain, I think it might help them reason as to why, if they're not kind of if they're not able to process the general kind of reasons. But I think in general the CBT, if the patients recognise why if we're talking about back pain and amputees, if they recognise why they've had an amputation, I think that will probably help them recognise why they're getting that back pain sort of thing.
Brilliant.
I've just actually started using acupuncture, so I've had a few patients that have tried it on and tried using it on. TENS we've used quite a lot, and that has varying effects, obviously, in terms of the patient and in terms of the area we tend to use it on. The patients that I've kind of used acupuncture on, it has been quite beneficial. It's like quite more of a, I guess, more of a global relief for the patients rather than more of a specific kind of specific point, but actually we never couple just TENS or acupuncture on its own. Generally we'd do that in conjunction with an exercise program and also the normal rehab that they're doing as well. The same as we'd say for any patients really, not staying in one position for too long, trying to avoid obviously sitting in the wheelchair is the main thing for too long. Yes, they're going to be in it for a long time, but maybe even if you just transfer from wheelchair to a chair, try and do regular exercise, thinking about posture when they're doing their exercises, and then if they're at a stage where they're prosthetic wearing, obviously making sure that their prosthetic limb fits them correctly and is working adequately. If they need an aid, to use one, because that's one of the key things. People try to progress themselves too quickly, end up with an altered gait pattern, which obviously causes them kind of problems further up the chain. And then to get regular, for amputees, to get regular prosthetic appointments to kind of make sure that they kind of come in on a regular basis rather than leave it too late before things are out of control and they're having problems with their back and they're having problems with their limb and things like that as well. And try not to get into habits of try and walk as well as they feel they can, rather than trying just to make do, because they're going to get further problems down the line as well.